preparing, setting up. All right. Thank you guys so much for joining us for the first edition of Lunch a la Carte for 2025. We are halfway through our fiscal year, beginning a new year. So happy new year to everyone. Thanks for being here. A lot of activity going on with CART. And the first thing I just want to mention to everyone is that we hope everyone has had a happy new year and is safe given all the crazy weather and things that are going on. But also remind you that we have 2 monthly meetings, one being this one, Lunch a la Carte, which is held at a lunchtime every month with a different previous CART researcher. But also we have a monthly call that we call CART Conversations, and it's held on the 3rd Thursday of every month from 5:30 to 6:30 p.m. Eastern Time. And it is open to anyone who is interested in learning more about how they can get involved with CART as a volunteer, as a fundraiser, sharing public image ideas, and all kinds of advocates and champions for our cause. And so if you are watching this live or on the recorded version on YouTube, we hope that you will consider joining us on the 3rd Thursday of every month. The link and the registration is on our website calendar at cartfund.org. We're excited about today's speaker, and without any extra time from me, I'm going to pass it over to past district governor and one of our board members, Tammy Mosteller, who is going to introduce today's speaker. But you're on mute.
Okay, now can you hear me? Perfect. Thank you so much, Tiffany. Today we're going to have Dr. Catherine Diaz-Asper, and she's an associate professor of psychology at Marymount University in Virginia and a fellow at Marymount Center for Optimal Aging, which focuses on research and education to advance the health and well-being of older adults. She has an active research program that focuses on using artificial intelligence to analyze speech, to screen for cognitive decline and dementia, and has received funding from the National Institute on Aging and Rotary's CART Fund for this work. So thank you, Dr. Diaz-Asper, for all that you are doing. We're now going to turn it over to you.
Thank you very much. I'm delighted to be here today to talk to you about my research. I'm just going to hope that I can get it up and going for you. There we go. Okay, so as Tammy said in the introduction, I'm an associate professor of psychology. I have been interested in screening tools for early cognitive decline for a number of years now, and I'm particularly interested in trying to leverage some of the advances in artificial intelligence to be able to do this. And so today's talk will be a little bit of the background, some of the work that we've already done, including work funded by CART, and then sort of some future directions of where I hope this work is going to go. So we'll start by sort of the big question that I think is important is, why do we need a new cognitive screening tool? Because there are plenty already out there. There are plenty of screeners for Alzheimer's disease and related dementias already available, but they have varying levels of sensitivity to the very earliest stages of decline. And those are the stages that we want to be able to capture when hopefully these new amyloid and tau clearing treatments will be the most beneficial. What we've found is actually that there's a problem of access to these sorts of tools for people that are unable or perhaps even unwilling to get to specialists for testing. And so various underrepresented groups fail to be tested until their disease process has really progressed markedly, in which case, you know, at that point, there's very little that can be done. Now, there are screeners that can be delivered remotely, for example, over the telephone, but they're generally not that great at being able to detect the earliest stages of decline. And so what it really is needed is a tool that retains the accessibility and the ease of use of the telephone, but is more sensitive to early cognitive decline than what current tools are. And so we decided to look at whether speech recorded over the telephone could be analyzed by the latest artificial intelligence technologies to detect decline. Now, it turns out there's actually a good body of evidence that supports the finding that a person's speech becomes impaired in Alzheimer's disease, with studies dating back as far as the 1980s. Showing that impaired speech and language can predate a dementia diagnosis by years, if not decades. And perhaps the most seminal work done in this area was by David Snowden and colleagues with the nuns study here, the Time magazine graphic here on the left, where they looked at nuns that had passed away and had evidence of Alzheimer's disease. They found that when they entered the convent some decades earlier, they had written essays, and the researchers found that the essays of the nuns that went on to develop Alzheimer's disease were simplified. They had less sort of complex ideas in them, and their language was not quite as complex as those that went on not to develop Alzheimer's disease. And there have also been studies on famous authors and other people. The middle photo there is of Iris Murdoch, who was a very famous British writer, prolific writer, who was known for rejecting editorial interference in her writing. And so her published novels very much reflected what she wanted them to say. They didn't have editorial interference. And the last novels, before she in fact passed away, she was diagnosed with Alzheimer's disease. Her last few novels showed a real lack of complexity in her writing, and they really went downhill quite markedly, to the point where her last novel was actually panned by reviewers. And then finally, on the right-hand side, we have former President Ronald Reagan. There have been studies showing that the speech he used when answering reporter questions after formal speeches became simplified over time, had more filler words, ums and ahs, less complex nouns, that sort of thing. And so, sort of to summarize, there's been many studies since then that have shown that language does tend to deteriorate in Alzheimer's and related dementias. And so if we could use that as a sign, maybe we could pick up this decline earlier than current tools are able to do. And so we wanted to use some of the latest artificial intelligence technologies specific to speech and language. And on the screen here, you can see just a handful of these language technologies that use artificial intelligence. And you may be familiar with a few of them, in fact. For example, natural language processing, or NLP, is the branch of artificial intelligence that deals with training a computer to understand, process, and generate language. So several different NLP methods exist, but they typically involve breaking speech or text into discrete subunits and then comparing these to a database of how these units fit together based on past experience. Automatic speech recognition, or ASR, uses artificial intelligence technology to process human speech into readable text. ASR and NLP are actually very closely related fields. They often work together to enable applications like virtual assistants, think of things like Siri, transcription services, language translation systems, that sort of thing. So once the speech is transcribed by ASR, NLP can process the resulting text to interpret meaning or take actions based on commands, Alexa, open something or other on my computer, or what have you. Now, machine learning is the process of applying statistical algorithms that teach machines how to automatically learn and improve from experience. Deep learning is a type of machine learning that can recognize complex patterns and make associations in a similar way to how humans do. It relies on large data sets and lots of computational power. And as the availability of these two things has increased, deep learning models have become more sophisticated. And lastly, large language models, or LLMs, use deep learning to understand how words and sentences function together. So many LLMs are trained on data that's been gathered from the internet, thousands or millions of gigabytes worth of text. One of the most well-known uses is their application as generative AI. So when given a prompt or asked a question, they can produce text in reply. So a well-known example of this would be ChatGPT. So in our research, we predominantly used NLP and machine learning to analyze the speech of older volunteers who were either cognitively healthy or had pre-existing diagnoses of either mild cognitive impairment or mild Alzheimer's disease. So here I have a schematic that shows you the basic procedure of our studies. So we would call the participant on the telephone at a convenient time, usually when they were at home, and we'd record the interview, which included a standard telephone screening test for dementia. It's called the Telephone Interview for Cognitive Status, or TICS, as well as 2 tasks to elicit samples of speech. One was to recall a favorite memory from childhood, and the other was to name as many animals as possible within a 1-minute time limit. We also asked participants to rate their level of satisfaction with the interview procedure. The recorded speech samples then underwent NLP to extract speech features that differed by which diagnostic group a person was in. And then those features went into a machine learning algorithm to predict which group a person was in. So our first study, which was funded by NIH, included 91 people, with roughly a third in each of the 3 diagnostic groups. Our second study, funded by CART, included slightly fewer people than we had originally hoped for, because it occurred during the COVID-19 pandemic and lots of things shut down, and people weren't quite as willing to participate in research, which is perfectly understandable. So from the first study, we found that certain features of a person's speech could indeed differentiate people who were cognitively healthy from those with MCI, mild cognitive impairment, and mild Alzheimer's disease. For example, the length and timing of pauses in the speech and how coherent or related each part of the text was to the next part were different between the groups. So on this slide, the pink curve shows the participants with mild Alzheimer's disease. The green shows the healthy control participants, and the blue, intermediate between the other 2 groups, shows the participants with mild cognitive impairment. So the top language and acoustic features that differentiated the groups were then entered into a machine learning model, which was very successful at predicting whether a person had mild cognitive impairment, Alzheimer's disease, or was cognitively healthy, as you can see in the top table here. So our best classification accuracy was comparing or predicting whether a person had Alzheimer's disease versus whether they were cognitively healthy, and the machine learning algorithm got that right 88% of the time. Even the least accurate, which is actually the hardest distinction, distinguishing between each of the 3 groups, was 75% accurate. So that's pretty good. And in fact, the lower table shows that the machine learning approach was in fact more accurate than 2 commonly used dementia screening tests that are used today. That would be the TICS, the one that the telephone interview, and the mini mental state examination. It was also more accurate than a clinician who had read the transcripts of the participant's speech. In other words, the artificial intelligence had better accuracy at discriminating groups than either a human or standard screening tests. We also found that participants enjoyed the interview process overall and rated the recall of the childhood memory as the most enjoyable, the easiest, and the least anxiety-provoking task. So these results were really promising, but we wanted to see if they could be applied to a new set of people. So in our second study, we retested a small group of the original 91 participants and also tested a new group of volunteers for the first time. So we found that some of the language features that we found in the first study remained significant predictors of diagnostic group in the second study, mainly those from the task where participants had to generate the names of as many kinds of animals as possible in 1 minute. A model trained to classify the 3 groups from the first study on the childhood memory task did about as well or slightly better when tested on data from the second study, but overall had only modest accuracy. The accuracy was around 65%, so it wasn't quite as good. This graphic shows that the language features looked similar between the 2 data sets, the first one, the NIH data, and the second one, the CART data. We also found that a model trained and tested on the combined data set of both the first and the second study was overall more accurate than training on one data set and testing on another. This is presumably because there would be more people included in that analysis and therefore more data for the machine learning model to learn from. And then finally, we asked a group of 50 clinicians who specialize in the diagnosis of Alzheimer's disease and related disorders whether they would be receptive to a screening tool such as this sort of thing in their own practices. And the majority said that they would be, about 73%. So we can say that we've developed a remote method for cognitive screening that's accurate at detecting cognitive decline associated with Alzheimer's disease. It's well liked by the people who take it and has the interest of clinicians who work in the area of dementia diagnosis. So then what's next? One thing I was very curious about was whether these artificial intelligence methods could detect decline in a person over time. So as I said, in our second study funded by CART, we retested some of the people that we tested in our first study. And that was done about 2 years after the first study. So these graphs here show that according to the standard cognitive screeners, the mini mental state examination and the telephone interview for cognitive status, people in each of the 3 groups really didn't change that much over the 2-year time interval. In other words, they didn't really decline in terms of the screening tests. So as you would expect, the blue line here indicates the healthy controls. The green line indicates the Alzheimer's patients, and then the middle orange line indicates those with mild cognitive impairment. And as you would expect, they were intermediate between the other 2 groups. But really, we see no significant decline in these 2 types of tests over time. But if you look at the artificial intelligence derived features from that animal naming task, you can clearly see that the mild cognitive impairment and the Alzheimer's groups declined quite significantly over the 2 years, whereas the healthy controls either remained the same or even improved slightly. So this suggests that the artificial intelligence method is in fact more sensitive than standard screeners, not only at detecting cognitive impairment at the current time, but also tracking it over time. It seems more sensitive to decline than the standard cognitive screening tests. So that bodes well for future applications. But we still have a number of questions that are unanswered when it comes to the application of the screener at scale. So some of these questions that I've put here to consider are, first of all, what are the best speech prompts? So in other words, what question elicits the best samples of speech for our artificial intelligence to learn from? Our study looked at the animal naming task and the childhood memory task. It turns out the animal naming task maybe was a bit more sensitive than the childhood memory. In our second study funded by CART, we also asked people to recall a story that they'd heard and also recount the story of Cinderella. So we'll be looking at the results of those prompts as well to see if they're more sensitive in terms of the features that can detect which group someone is in. The second question that sort of we need to investigate further is whether and how appropriate the models are that we derived from our data when applied to new data. So in other words, the participants in our studies were generally very well educated. Most of them had a bachelor's degree or better or more education. They were predominantly white. So what we don't know is if we use a model based on well-educated white people, how that is going to do in a different demographic. And so those sorts of studies need to be done because otherwise the machine learning models are really only useful for the people that they were trained on and not anyone else. So it would have limited applicability to new groups. So that's an important question that remains to be answered. The third one is, can the interview be fully automated? So when we did these two studies and our ongoing studies, we actually had a research assistant call participants at home, chat with them about the study, give them encouragement, answer questions, all of that sort of thing. So that's probably not feasible if you're going to come up with a tool that can be used all over the country and multiple times and all of that sort of thing. So it would probably need to be a fully automated system. But we found anecdotally from our participants that they preferred speaking to a real person. They could ask questions and have them answered and didn't have to deal with the automated system misunderstanding what they said or something like that. And so these are very real concerns that would need to be addressed before any sort of model could be put forward as a tool. And then one of the other major questions that need to be answered is whether this approach can be used for non-English languages. So the vast majority of resources for artificial intelligence in speech are in English, which makes sense because it's such a major language around the world. However, English is not spoken by everyone and it is not applicable to all populations. And so when we start talking about languages that don't have as many artificial intelligence resources devoted to them, it makes designing models and approaches that much harder. And so one of the areas that I'm particularly interested in at the moment is seeing whether this approach can be used in non-English languages, specifically Spanish, of which some work is already being done by other groups, and then some other languages that are perhaps even not as well spoken or by as many people as Spanish is. So those are some of the questions that we have moving ahead with this particular area of research. So that's pretty much sort of coverage of my research to date and where I'd like to go in the future with it. I'd like to especially thank the participants in our studies, of which without them there would be no findings to report to you. Obviously, I'm eternally grateful to the CART Fund for funding this research. I'd like to thank my collaborators, Scott Turner and Bridget Reynolds at the Georgetown University Memory Disorders Program. They were invaluable in referring us individuals to participate in our studies. My collaborator, Brita Elvervorg at the University of Tromsø in Norway, and Chelsea Chandler at the University of Colorado Boulder. So now I would love to be able to answer any questions that people may have.
Fabulous. So let me ask this question. What's next for you? Like what do you envision as what will happen with this test next?
So it's a great question. At the moment, I am applying for funding to do further research. the niche I think that my research is in, compared to many of these other larger institutions and larger research groups, is that I'm focusing very much on just the ubiquitous telephone. Many groups are using smartphones and apps, and that's fantastic. And they will find great results using that. But I think I'm particularly interested in sort of the real world applicability of just being able to have someone call on the phone and record what they say and analyze it. I think that has huge potential, not just in the United States, but worldwide, to be able to address this issue of underdiagnosis of cognitive decline. So that's an area that I'm, particularly interested in. Marymount University is a small university. We've got a lot of great individuals working in aging research, but we don't have the facilities and the resources of some of these larger places, even, private firms that are doing this sort of research. So I think, my niche being the telephone, and also perhaps looking at other languages and some of these sort of more focused questions, I think, is where I'm going to take it, rather than try and compete with, these larger places. So, but I think regardless, there's a huge amount of potential in these sort of digital interventions and tests for people that certainly AI is here, and it's here to stay, and it's going to change and advance in the future.
Any other questions? I know you mentioned the two researchers at the end who helped identify the individuals as part of your study. Are they medical doctors that have patients that they referred in? And
yes, so Dr. Turner is in charge of the memory disorders program at Georgetown University, the hospital there. He's in the Department of Neurology. So, and Bridget Turner is the nurse practitioner in charge. And so they both, between the two of them, they have a large database of research participants for their studies, and they very kindly, opened that up and allowed us to be able to reach out to many of their research participants to take part in the study. And the nice thing was, because they see participants clinically, or patients clinically, that have these diagnoses, we were also able to work with spouses and family members as our healthy controls, because they were all part of the same sort of cohort. So that made it really nice.
that makes sense. Sure.
So that's one of the, oh, sorry.
No, go ahead.
That's one of the areas that I'm also now trying to sort of make advances in, is to then apply this to people in the community, right? So we sort of, I think, provided proof of concept that this approach seems to work, and it seems to be more accurate than what's already out there. But we had very well-defined, well-phenotyped groups of participants. What I'd like to be able to do is just take this out to people in the community that don't necessarily have any sort of formal diagnosis from a doctor, and just see whether we're able to detect any sorts of impairments. And hopefully, in the majority of cases we won't, but there are a lot of people in the community that do actually worry about their memory, and they don't have perhaps the resources or the ability to be able to get screened and get tested. So this is a great way to, to try and bridge that gap.
I remember I worked for a hospital system for a while that had a community education center, and I could see this being a really good program that they could offer in those type facilities, community health centers even, but definitely the education centers have a day of screening, just like we do for skin cancer and other issues. Mm-hmm.
Right. Mm-hmm. Absolutely.
And so you mentioned early on about the nun study, which I was not familiar with, so I'll have to go back and look at that, but also talking about Ronald Reagan. And so I thought that was fascinating. So are you able to go back and look at speeches of people and see a difference over time, especially for someone like him that we have so many recordings of, I guess, over the years?
And that's what the researchers in that particular study did do. They went back. You have to be a little careful, though, because things like speeches are probably written by speech writers, right? So there's, there might be some input from other people. So you really want to make sure that the speech or the text that you're looking at is completely generated by that individual. And so in that particular study that I'm referring to, they actually looked at the question and answer session responses after the speech was given. And so in comparing that with former President Bush, they showed that, former President Bush over time stayed exactly the same, whereas former President Reagan, declined in these sort of key areas of generativity of his speech.
Do you ever find yourself wanting to do that on people that are in the public eye now and going back and comparing and see? I mean, I'm thinking
I
about
don't want
me,
to
and you
touch
said,
that with a 10-foot
I understand.
baseball.
And I'm
No.
not speaking of anyone in particular, just saying that, like, for me, for example, I speak all the time and I don't have a speechwriter, obviously, except me. But I'm thinking, wonder how different my presentations are from 10 years ago to now, not just in content but delivery and things like, I mean, you got me really thinking about myself as much as anyone else.
I mean, to me, it's a fascinating area because much of the research that I've shown today focused on, the words people said and how they related to other words people said and things like that. But there's also the whole issue of the speech signal itself, like, how you enunciate and the number of pauses you have and where those pauses happen and all of these sorts of things that I think would be pretty much impossible for a person to work out while listening to someone, but that these automated artificial intelligence tools can do just like this. It's no effort. And so you can get this really rich data. Then the problem is interpreting it, knowing what it means. Is this actually an important piece of diagnostic material, or is it just, some confound that really is not relevant? And I think the field in general is sort of parsing through that now and trying to work out exactly, how important each of these features are. So I'm very careful to say that this test is not meant to be diagnostic. It's not a blood test for Alzheimer's disease or anything like that. All we can do is say that the features are consistent with a level of cognitive impairment. But a level of cognitive impairment does not mean that you meet diagnostic criteria, because of course having a diagnosis of mild cognitive impairment or Alzheimer's disease relies on a lot more than just a screening test, right? So to me, it's more of a tool that could be used to flag individuals to then get further testing, right? So, and for people, hopefully the worried well, to say, okay, you're actually fine. You don't need to go and see a specialist yet. Come back in 6 months to a year, do the test again, And that's one of the great things about using speech, is that many of the currently available tools suffer from something known as practice effects, meaning that if you take the mini mental test today, you shouldn't really take it again for another 6 months, because within that time interval, you could remember the answers and perform better because you remembered what you did last time. Whereas with speech, there are potentially an endless number of questions I could ask you, and an endless number of answers you could give me. And so speech doesn't suffer from that sort of shortcoming of many of the other sorts of tests that are available. Obviously, new biomarkers are a huge an exciting area to be able to screen for cognitive impairment and Alzheimer's disease. And what I'm proposing wouldn't compete with that. The difference is that, at least at the current time, biomarker technologies still require the person to get to a hospital or a research center or a specialist to have that blood test or that brain scan or whatever else. And so these sort of quote unquote digital technologies may be the way of the future to reach people that are otherwise unable to get screened.
I don't mean to take over. If anybody has any questions, I'm just fascinated by this. Do you think there's any consideration given to auditory issues during something like a phone test? Because obviously, when my mom first started her cognitive decline, I argued for a year that there was nothing wrong with her mind. She simply couldn't hear what we were saying. And that every time we asked a question and she didn't have an answer or, I argued with my brother that it had to be her hearing until we took her to a hearing test and it was fine. And so I'm curious if there's any consideration into that with this kind of test.
Yeah, excellent question. And in fact, hearing loss is a known risk factor for Alzheimer's disease. And so if hearing loss becomes an issue as you age, you absolutely should get that taken care of, because your risk for developing these conditions goes up if it's not treated. Yes, and I need to be very clear, in the participants in our study were screened so that if they had significant hearing loss to the point where they were unable to hear well over the telephone, they weren't included in the study. In fact, no one met that criteria, because the people that did have hearing issues had speakerphones and hearing aids and other ways that they could hear. But that is a potential concern when you're using the phone, that you are sensitive to things like that. Also, this technology, we didn't really look at people that have speech impediments, or, for example, if you've had a stroke and speech is difficult, that would impact the accuracy of these sorts of tests. So they are, I think, in theory, widely applicable, but there are certain characteristics that would make them less accurate and therefore not appropriate for a particular population.
I know it's not your area of expertise, but are there folks out there that are doing research regarding the audiology aspect, the hearing loss, and as how it correlates to the cognitive decline? Because we really don't hear that much about it. It came up in a call that we were having last night, and one of our donors said his doctor recommended a hearing screening because of their family history, and no one on the call had ever heard that before. So we were surprised by it.
Yeah, I think it's becoming more widely known in sort of primary care circles that it is a notable, significant risk factor for cognitive decline and dementia. And so hopefully with that knowledge, more people will be screened for hearing issues. I think in the past, you're very correct that we would assume that someone that wasn't hearing well, you don't really know much about their cognitive state because they're not participating in conversations because they can't hear. And so, it became this big confounding factor that got in the way of being able to work out whether they were cognitively healthy or not. And so, but there's really good evidence now that it's a significant risk factor.
Do you have any plans to do this study with other languages?
Yes, I am working with some colleagues, and I'm going to submit a grant application very shortly to look at, believe it or not, Amharic, which is the main language in Ethiopia. The reason for this is that the Washington, D.C. region has the largest population of Ethiopians outside of Ethiopia. And I'm partnering with a clinician in Ethiopia who's doing work on cognitive screening there, because the infrastructure is not as well advanced as it is here in the States. There's a lot of stigma. And so it's a population that is hugely understudied. And so I think it's right to be doing this sort of research. And from my perspective, if we can develop a model that works in this particular language, I think it lays down the foundation, or lays a blueprint to then apply it to all other languages that have, less resources in terms of artificial intelligence. And so, it may seem like this very niche kind of language to look at, but I think to me, it serves not only to help this population, but also secondarily to develop an approach that could be applied to many other languages around the world. People in the United States speak so many different languages, and many of them are uncomfortable talking to their doctors if they don't understand that language, or they don't have the words in English to explain their symptoms. And so this would be a great way to address that.
what advice do you have for folks who are either on with us today or maybe watching afterwards? Maybe things they should be watching for or listening for in their family members if they have concerns of cognitive impairment. What are the kind of warning signs that ought to at least trigger the thought of should we have some further testing done?
Yeah. Well, specifically in terms of language, we all have, slips every now and again and forget the word for something, that tip of the tongue thing. I can't think of it. If that word comes to you at 2 a.m., which is done to me before, you're probably fine. That's what we would consider part of normal aging. But if it's a concern to the family member and to the individual that they've noticed that, yeah, it's getting harder to come up with words every now and again, that might be something. Generally, when people go to their physician with concerns about their memory, they're valid concerns. It's not often that people are going to show up to their doctor with all these concerns that they've got dementia when they're perfectly well, right? So I would say that the individual concerned and their family members are the best people to sort of appreciate any changes. So in terms of memory, it might be, I always have to put my keys in the same place because I always forget where I put them. Otherwise, I lose my phone.
I feel like you're talking
that
about me right
becomes,
now.
or the one where you walk into a room, what did I come in here for? The more times that sort of thing happens and the more unusual it is for you, I think those should be areas that you can just go to your doctor and say, look, I'm a little concerned about this, or I'm a little concerned about my family member with this. And it's very easy for them to give you a quick questionnaire or something like that. Now, we've talked about the fact that they're perhaps not that great at detecting those really early stages, but at least you've got that documented in your medical record that this is something that needs to be followed up, so that 6 months, a year later, you can go back and they can do that same test again and see if there's any changes.
But I think what's interesting is that your study, your research shows that it's more than just forgetting a word. It might also be, as you said, the pauses or the delivery style, pronunciations. It could be any of those things that are warning signs, maybe,
Right.
or at least items of concern, if not
right.
warning signs.
Right, and that are not picked up by these sort of standard screening tests. I agree, I think that's absolutely right. I do, want to issue the caveat that our studies are relatively small. We're not talking hundreds and hundreds of people. And so I would love to be able to replicate them in hundreds and hundreds of people. But anyone who's done clinical research that doesn't have sort of a ready supply of volunteers waiting will know that it's fairly laborious to get people signed up and get them involved and do that testing. So it's a fairly time-consuming process, and of course, one that requires money to be able to do. And so that's why researchers, at smaller institutions such as myself, spend a lot of time trying to generate that, writing grant applications to be able to do those sorts of studies. But yeah, they do, generally need lots of people to be able to get the sort of robustness of the findings. Certainly, I think our findings are very exciting and suggest quite strongly that this approach is very sensitive, especially to being able to pick up these very early signs, but it needs to be replicated in larger numbers of people.
So you mentioned that you had your study with CART was right about the time that the world started shutting down, and so you had to approach things a little bit differently. But could you just for a few minutes just share kind of what it meant to you to have a grant from CART and what that meant to your research?
Oh, it was huge, absolutely huge, because I had done that first study that was funded by NIH, and I had applied to do this research. It needed we needed to do some more things to what we'd done in that NIH study. So like I said, we asked some different questions. We approached some things a little bit differently to see, particularly about the speech prompts, like which are going to be the best prompts to use. And so if I hadn't been funded by CART, the research really would have stalled at the point that I had, which is, it's okay. I got some publications, all of that sort of thing is great. But I think I was left with more questions after my first study, and I wanted to address those. And CART really provided the resources for me to be able to do that. And working with the team has been fantastic. So, going from a government grant to a foundation grant was a learning curve for me, right? The government has lots of paperwork and great. Whereas CART, I could just email and talk to real people and get answers and submit forms and it was just much more human. There was a much more human face to it. I also had the honor of being able to present at one of the regional meetings and to meet some of the Rotarians involved, and that was just mind-blowing. I mean, it's one thing to be able to say, well, I'm funded by this group. It's quite another to meet members of the group and hear their stories and realize the lengths that they've gone to help address the issue of aging and dementia. This is knowing the history of CART and just, coins in buckets, and then it's got to this huge funding mechanism, and a very competitive one now by the sounds of it with those numbers of applications. I'm very, very proud to say I'm a recipient of some of that funding because it's really enabled me to move this sort of idea forward into something that's becoming concrete. And it came at a crucial time. I really, like I said, if I hadn't had something after the NIH grant finished, I would have stalled, and then COVID hit and nothing would have happened for years. So with the CART funding, even though COVID hit, we were still able, though we moved slower, we were still able to move forward. And I think that's made all the difference.
That's great. Thank you for sharing that. We are certainly grateful. I know I enjoyed being with you at that district conference that you were at in South Carolina, and we encourage all of our Rotarians to think about inviting one of our researchers to their district conferences, to their special events, because I think that as much as you said it was a great experience for you to hear their stories, it is always a wonderful experience for us to hear directly from you all as well, especially in a situation like that. And you're right, everywhere, each of us as CART volunteers, everywhere we travel, we hear those individual stories, and we are motivated to continue doing what we do because of those stories and because of people like you. So we are very grateful for your time today. We are grateful for the work that you're doing and your kind words about the CART Fund as well. And we certainly hope that you will choose to apply for a CART grant again someday. And we are proud to have you as one of our partners.
Great. Thank you so much. And thank you everyone for watching today.